السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. اللهم لا سهل إلا ما جعلته سهلا وأنت تجعل الحزن سهلا. Dear colleague, ladies and gentlemen, السلام عليكم ورحمة الله وبركاته. باسم أعضاء إدارة جمعية طب الأطفال السعودية حديث الولادة، أرحب بكم أجمل ترحيب في هذا الصباح الجميل وفي هذه المنطقة الزاهية والتي ازدادت زهوا بوجودكم، فتدمع العين لرؤيتكم مرة أخرى في قاعة مؤتمرات الملك فيصل. دأبنا في الجمعية للبدء في كل أبريل، والسنة هذه لظروف البان كورونا أخر المؤتمر إلى نوفمبر، وكان الجهد الجهيد لتنظيم برنامج المؤتمر، تنظيم شركات الداعمة، كلف الكثير من الجهد والمال، لكن من أجلكم يهون كل شيء. فلا نأخذ الكثير من الوقت، نبدأ السيشن الأول Respiratory Support، وخير من نبدأ به هو من أبناء بلد الكنانة، الدكتور ياسر السيد. قال لا تقدمنا كثير، لكن أنا أخجل عندما أقدمه لأنه ما شاء الله تبارك الله. He is coming from أرض الكنانة لكندا مانيتوبا, get his fellowship in neonatology, and then he became one of the figures in the hemodynamic aspect, director for the neonatal hemodynamic and echo, focus group, point care ultrasounds. And Yasser, he became one of our members actually. In every national conference, he is one of the figure and stars. وانا دائما لما اقدم اقول محمد صلاح الطب، محمد صلاح الرياضه، وياسر السيد محمد صلاح الطب. Dr. Yasser Syed is going to talk about neonatal pulmonary hypertension. Dr. Yasser, the floor is for you.
Yeah, thank you very much. يعطيك العافية. السلام عليكم ورحمة الله وبركاته. I would like to start first with thanking the organizing committee for inviting me for this great conference. And it's my pleasure to be here in Saudi Arabia. It's I consider that I'm within my family and in my country. I never feel that I'm a stranger within this community and in this country. So thank you again. And to save time, this presentation is about management of pulmonary hypertension in neonates. And I will discuss in this presentation the management aspects of pulmonary hypertension as a spectrum of disease, not just one entity. First, I have nothing to disclose in this presentation. And I have three main objectives to discuss over the next 30 minutes or so. At the end of this presentation, you will be able to, hopefully, number one, demonstrate the physiology of pulmonary hypertension. Second, demonstrate the 5 main phenotypes of pulmonary hypertension. So pulmonary hypertension is a spectrum of diseases, not just one disease. And then demonstrate the therapeutic options and intervention algorithm. So at the end, I have management algorithm that you might use it at the bedside to diagnose and intervene with pulmonary hypertension. And it is based on the Canadian Pediatric Society position statement. So I have divided my presentation into 5 main sections based on the 3 objectives. First, I will discuss the basic physiology of pulmonary hypertension. Second, which is the most important part, I will describe the physiologic clinical phenotypes, and then how to diagnose pulmonary hypertension based on the clinical echocardiography and other diagnostic aspects. Third, I will discuss the therapeutic options of pulmonary hypertension, and then at the end, the management algorithm. To start with the physiology, we have to remember our history. And the first description ever on pulmonary circulation was from Ibn Nafis. Ibn Nafis, the chief of Cairo Hospital, 1288, who is the first scholar to describe pulmonary circulation, which was published and translated into so many European languages. That was 500 years before discovery of oxygen by Joseph Priestley. So Ibn Nafis, when he described the pulmonary circulation, he described gas exchange within the lung, but he did not consider oxygen as a main gas for exchange, because oxygen was unknown until described by Joseph Priestley 500 years later. So when we talk about pulmonary hypertension, we need to integrate between the concept of pulmonary circulation and ventilation, or oxygen. And this comprehensive slide includes almost all of the pathophysiologic mechanisms that might affect oxygen delivery. So if you are working in intensive care, regardless the type of the intensive care, if you are working in NICU, PICU, or adult intensive care, if you move across the admitted patients in the unit, you will recognize that every single patient, or all of the patients, they have at least one of the pathophysiologic mechanisms in this slide. On the left side of the screen, you can see infant at risk of hypoxemia. On the right side, infant at risk of hypoxia. So hypoxemia can be due to one of the 6 main pathophysiologic mechanisms: limited diffusion, when there is a thickening of alveolo-capillary membrane, or could be due to right to left shunt, which could be intracardiac or intrapulmonary right to left shunt, hypoventilation, pulmonary congestion, pulmonary hypertension, which is our topic today, and the most common mechanism is VQ mismatch or ventilation perfusion mismatch. On the other hand, if the infant at risk of hypoxia, it is typically related to blood flow or anemia, so it could be due to low preload, low systemic vascular resistance, or hypotensive shock, high afterload, or vasoconstrictor physiology, poor myocardial performance, left-right shunt, and then anemia. So our talk today will focus on infant at risk of hypoxemia and pulmonary hypertension as one of the main pathophysiologic mechanisms that might cause hypoxemia. The clinical limitation of pulmonary hypertension, that we have 3 main clinical presentations for any infant with pulmonary hypertension or systemic compromised systemic circulation: hypoxemia, acidosis, and systemic hypoperfusion. That's why we have to rely on other investigative mechanisms. So this slide describes the ventilation perfusion coupling, which is a concept of ventilation perfusion matching. The amount of air in the lung should be matching the circulated blood. So in the middle, we have ventilation perfusion matching is at close to 1. In real physiology is around 0.8. If you move to the right side of the screen, you have less ventilation with normal perfusion. So you have the ratio is less than 0.8, is 0.6, 0.4, 0.2, until you reach the extreme, which is no ventilation at all. You just have the blood is moving through the lung without any gas exchange. So you have ventilation of 0 over perfusion of 1, which is extreme of right to left shunt. So this is typically present in pulmonary hypertension due to lung congestion, so too much blood and less air, pulmonary venous hypertension, or lung collapse. On the other hand, on the left side, you have pulmonary, like the ventilation is okay, but you have pulmonary circulation is affected. So you have decreasing perfusion or hyperinflation. So the ratio is the opposite, 1.2, 1.4, until you reach ventilation 1, normal, and you have the circulation is 0. There is no blood. So it is the same like dead space, sorry. So you have a dead space, and this in situation when you have no blood at all, or high resistance limiting the blood flow, like pulmonary hypertension due to pulmonary vascular resistance high, or shock, or lung hyperinflation. This slide explains the importance of having the lung well inflated before you consider nitric oxide or consider pulmonary vasodilator. So in this slide, you have the y-axis represents the pulmonary vascular resistance, x-axis represents lung volume. So to get the pulmonary vascular resistance acceptable, you need to get the FRC maintained functional residual capacity, so the lung inflated just at the FRC, if there is small lung volume, so you have the left side of the screen, so the pulmonary vascular resistance is expected to be high. On the other hand, if you have hyperinflation of the lung, the pulmonary vascular resistance also expected to be very high. So you have to maintain the lung at the functional residual capacity to get the least pulmonary vascular resistance. That's important before you consider pulmonary vasodilator. So to understand the physiology of pulmonary artery pressure, just remind you that pulmonary artery pressure is the same like systemic pressure. It is directly proportional to pulmonary vascular resistance multiplied by blood flow. Pulmonary vascular resistance can be affected or can be high as arteriolar high pulmonary vascular resistance, and also it can be in two situations, reactive, reversible, like in vasoconstriction secondary to hypoxia, like in PPHN, or irreversible due to hypoplasia of the vascular bed. That's common in pulmonary hypoplasia or congenital diaphragmatic hernia. It can be venous or venular when you have high venous pressure in pulmonary venous hypertension, or it's also common in left ventricular dysfunction. So the left ventricle unable to eject the blood out of the heart, so the blood will accumulate in the left ventricle, in the left atrium, and hence to the pulmonary venous circulation. When you have pulmonary blood flow, it can be high, like high pulmonary circulation due to congestion in PDA, in preterm infants, or AV malformation, or could be low pulmonary blood flow. We are not using pulmonary hypotension as a term, but it might happen actually in shock and right ventricular hypoplasia or severe RV hypertrophy, and that might happen in case of premature closure of the ductus in utero. The pathophysiologic mechanisms within this box will be presented with hypoxemia, but the last part in the red box will be presented mainly with the systemic hypoperfusion and also hypoxemia. So if I ask you this question, pulmonary hypertension occurs in increased pulmonary blood flow, or increased pulmonary venous vascular resistance, or increased pulmonary venous pressure, or all of the above. So makes sense now to be all of the above. So we are using PPHN as a term for pulmonary hypertension, which is not right. PPHN is just one spectrum. It is due to increased pulmonary vascular resistance secondary to failure of postnatal transition. But even when you have high pulmonary blood flow, it is another type of pulmonary hypertension, and that should not be treated with pulmonary vasodilator for sure. This slide just to show you very interesting findings which published about the impact of gestational age on pulmonary vascular resistance. Is not the same. So in y-axis you have the vascular resistance, which is in the red line is the systemic vascular resistance, and the blue line is the pulmonary vascular resistance, and x-axis represent the gestational age. So early gestational age between 22 to 27 weeks, you have very high pulmonary vascular resistance. That's why we expect very bad pulmonary hypertension that might happen in premature infants, might be really difficult to manage. And also near term and term, they may have very significant pulmonary hypertension. But in between, you have around 30 weeker, the least pulmonary vascular resistance, much easier to control the pulmonary hypertension. Now we'll come to the physiologic clinical phenotypes. We have common phenotypes that might be important to understand how to interpret each one of them and to manage each one of them. So first, just to describe normal cardiopulmonary interactions, we have, as I mentioned, ventilation perfusion matching around 1 or close to 1. It's typically 0.8. So you have the red color represent the blood and blue color represent the air. So both should be within normal. So typically we have 150 to 200 ml of air per minute, per kg per minute of air ventilated in neonates, and 150 to 200 ml per kg per minute of blood circulated. So they are closely matching. And you have minimal left or right shunt through PFO, dominant left ventricle, as you can see. And you have normal biventricular performance. You have normal systemic blood flow. And you have the right clip with the four-chamber view. You can see the left side is dominant compared to the right side. The contraction performance is normal, and you have then the short axis, the septum is rounded, represent that the left ventricle pressure is higher than the right side pressure. Now we have the high pulmonary vascular resistance with PPHN. So you have the right side dominance now. So you have first, the ventilation perfusion is more than 1 because you have more air than blood, or you have less blood because of high resistance. And you have dominant right ventricle, as you can see, and the apex is made by the right ventricle. But the performance is still good. And the systemic blood flow is still normal, so there is no hypotension. So the typical scenario here, the common scenario, term or preterm, is hypoxemic respiratory failure secondary to lung disease or perinatal asphyxia. And you can see here easily the right side is more dominant, more dilated, but the contractility is good. And the septum goes from right to left because of higher right side pressure compared to left pressure. And the PDA here is right to left. In this case, typically you need to accept target saturation 90 to 95 and the pulmonary vasodilator if needed in case of oxygenation is not enough to treat. When you start a nitric oxide in preterm infants, that should be very cautious because simply the PDA might shift in just 1 hour, shunt from right to left to be left to right. If you start a nitric oxide in preterm infant, you have to follow up by echo. Like sometimes we do that Q6 hour or 8 hours. Once you see the PDA shunt left right, will stop or wean the nitric oxide very quickly. Otherwise, the PDA might be significantly left right and might cause pulmonary hemorrhage or might also contributing to development of IVH. Then the second phenotype, you have pulmonary vascular resistance with RV dysfunction. Now you have more severe pulmonary hypertension, and you can see the right ventricle is dilated with poor contractility, poor performance, and it is dominant right ventricle with right to left shunt through the PDA, and poor ventricular performance mainly to the right side, but still normal systemic blood flow. In this case, continues the same management with oxygenation, nitric oxide, but you need to add another agent to improve the RV performance, which is merinon or dobutamine. As you can see here in the four-chamber view, very poor performance of the right ventricle, and the septum goes from right to left with poor performance of the RV wall. So you need to add an agent to improve the RV performance. The third type, which is really tricky and difficult to manage. Why? Because nitric oxide is contraindicated in this phenotype. It is a phenotype with LV dysfunction with pulmonary venous hypertension. As you can see in the echo view here, very high pulmonary venous return because of high pressure on the pulmonary venous circulation, the ventilation perfusion matching less than 1, dominant right ventricle, poor LV performance with low systemic blood flow, because LV will affect the systemic blood flow. This might be common in term or preterm infant with hypoxemia secondary to failure of postnatal transition, or can be also in high flow extracardiac shunt like AV malformation. In this situation, because of LV dysfunction, is contraindicated to use nitric oxide. Typically, the right to left shunt through the PDA is needed because it's compensating the low pressure on the systemic circulation. It's typically the same like left ventricle hypoplasia physiology. So you need the PDA to stay open to perfuse the left side. If you use nitric oxide or extra oxygenation, you will reverse the shunt. You will get this infant might die from systemic hypotension. So contraindicated to use nitric oxide in this case, and to accept target saturation less than usual, so 85 to 90, to increase the pulmonary vascular resistance, to help and encourage more blood shunted through the PDA from right side to the left side. So that's the most tricky part to manage. The phenotype number 4, biventricular dysfunction, is more severe. When you have both ventricles are not really contracting well, that might be common, like in this view here with the parasternal long axis view, and with the tachycardia, and the other example here with bradycardia, really severe biventricular performance. It might happen in premature babies due to postnatal transition. And in this situation, also don't use nitric oxide. You need to improve the ventricular performance first by medications like dobutamine. Because of low blood pressure, we may need to mix between dobutamine and another vasopressor like vasopressin or norepinephrine. Prostaglandin might be used in some severe situations in term infant if it is really difficult to control the systemic hypoperfusion. Sometimes we use prostaglandin to open the duct and help with the right-left shunt in this situation. The fifth type is really tricky, uncommon, fortunately, but we have seen maybe 1 or 2 cases every year. When the PDA closed antenatally before birth, it might be a disaster. So the common scenario, term or preterm infant with hypoxemia, usually normal during the first few hours, and then when you test for screening, pulse oximetry screening for congenital heart, you will see the saturation is really very low. That might happen with the premature closure of the PDA, and will be presented, as you can see here in this echo view, with severe hypertrophy of the left or the right side of the heart. And this situation, what you need to do is just monitor oxygenation, accept target saturation more than 75, no any troops contraindicated, no nitric oxide, because in this situation, this infant might be presented with low systemic blood flow, and avoid oxygenation unnecessarily. Again, accept saturation more than 75. It usually resolves within 5 days. And most of the situations, this infant might deteriorate because of the intervention, because of the physician wrong intervention, giving nitric oxide unnecessarily or oxygen, or misinterpret this case as typical pulmonary hypertension. So just side by side, you have the five phenotypes. The first one, you need to get good oxygenation after recruiting the lung with nitric oxide. Second time, you need to add Merinone or dobutamine. The third type, don't use nitric oxide. The fourth type, again, you need to improve the biocardial performance before using nitric oxide. The fifth type, it will improve by itself without any intervention within a few days after birth. How to diagnose? Typically clinical suspicion, echo confirmation, and some situation we need CT angio, catheter, or MRI. How much time do I have left? Sorry? Okay. Okay, thank you. So clinical evidence of pulmonary hypertension typically it is one of two things. So pulmonary hypertension clinically can be detected if you have pre and post ductal saturation difference more than 5%, but this only happen if the PDA still open. If the PDA closed, that doesn't make sense to check the pre and post ductal saturation. That's why after echocardiography done, and I have written in the report that the PDA is closed, I tell the bedside nurse or the RT, you don't have to check the pre and post ductal saturation. Doesn't make sense. The PDA is closed. The second clinical sign, desaturation. If you have near term or term infant who is more than 2 desaturations within 12 hours, you need to check the pulse oximetry screening test, and it is failed, you need to do echocardiography to rule out congenital heart disease or to confirm presence of pulmonary hypertension. Target neonatal echocardiography, we are not using the conventional echo by cardiology for the last 10 years to diagnose pulmonary hypertension. Pulmonary hypertension managed entirely 100% by the trained neonatologist in echocardiography for the last 10 years in most of the Canadian centers. So it is entirely neonatal management. In target neonatal echocardiography, pulmonary hypertension can be divided into, as per echo. Pulmonary hypertension is normal RV performance, and you need at least 2 of the following. You have TR jet more than 2/3 systemic. You have interventricular septum flat or pose from right to left, PD bidirectional or right to left, and then dilated right ventricle compared to left ventricle. And then you have pulmonary hypertension with RV dysfunction, and RV dysfunction can be diagnosed by eyeballing of the contractility or by what's called tricuspid annular peak systolic excursion, if less than 0.5. It is excursion of the tricuspid valve moving with the movement of the right ventricle. If the tricuspid valve does not move very well, it means the right ventricle does not move well. And then we can classify based on that pulmonary hypertension secondary to high pulmonary vascular resistance into 3 main categories according to severity. Mild, when you have 2/3 of the systemic pressure. Moderate, when you have equal to systemic pressure. And then severe, when you have suprasystemic pulmonary arterial pressure or with RV dysfunction. Tricuspid incompetence, as you can see here, it is the most common way to evaluate the pulmonary arterial pressure indirectly. So we estimate the the tricuspid incompetence pressure gradient, and we have the pressure gradient here, and you need to just add 5, which is the right atrial pressure, assumed right atrial pressure, unless you have central venous pressure to accurately estimate the right pressure. And then you have the systolic right ventricle pressure. It is equal to tricuspid valve gradient plus right atrial pressure. So for example, in this scenario here, you have the right ventricle pressure 62 at 5. After adding 5, which is right atrial pressure, and you have the systolic pressure of 50, so it is typically suprasystemic pulmonary artery pressure. And also you can use a ductal shunt. So if we know the pressure in the arterial side through the arterial line, and we know how to measure the pressure gradient through the PDA, then we can calculate the pulmonary artery pressure. So here you have the PDA right to left shunt. So you have the pulmonary artery, and you have the 3 branches of the pulmonary artery, the left branch, right branch, and the PDA. And the PDA is blue color, means the blood moving away from the probe. So it is right to left shunt. You estimate that the pressure by continuous or pulsed wave Doppler, and you have the Doppler pressure gradient of 10 millimeter mercury. It means that the pulmonary artery pressure is 10 millimeter mercury above the systemic. So simply, if you have the systemic systolic 50 at 10, so the pulmonary artery pressure is 60. So typically it is suprasystemic. So in our unit, we have what's called echocardiography triage. So if the neonatologists require echocardiography, and if the clinical condition with suspected congenital heart disease or cardiomyopathy or arrhythmia, then it is typically cardiology or pediatric cardiology category. But if the indication related to PDA or hypotension unresponsive to low dose of vasopressor, our limit is 10 mics per kg of dopamine or dobutamine. Above that, you need to consult for TN echo assessment. And the clinical suspected pulmonary hypertension or cardiovascular compromise, in this situation, you need to consider TN echo. And if the first echo ruled out congenital heart disease and it is pulmonary hypertension, the cardiologist will refer the case to me. So I will continue to follow up the case. And the opposite, if I did the first echo and the first echo showed there is congenital heart disease, I have to refer the case back to the pediatric cardiologist. So we are working as a collegial way of applying this echocardiography triage algorithm. So the fourth objective today, or the fourth section, therapeutic options, is one of the 3. Oxygen, nitric oxide, and the cardiovascular drugs. So in pulmonary vascular resistance high, we need to accept target saturation 90 to 95, and we are using, for the last 6 years, near-field spectroscopy. So the pulse oximetry is a 5th vital sign, and we added the 6th vital sign, which is near-field spectroscopy. So if we monitor the arterial side of the circulation, you need to get an idea about the venous side. And we can do that indirectly through using near-field spectroscopy or tissue oximetry. So we accept 60 to 80 to be sure that the tissue is getting enough oxygenation. In pulmonary hypertension secondary to high pulmonary blood flow, we need to increase the pulmonary vascular resistance to limit the pulmonary congestion. In this situation, we accept the lower target saturation 85 to 90, and the same for tissue oxygen 60 to 80. Nitric oxide, typically in pulmonary hypertension, secondary to hypoxemia, unresponsive to oxygenation, presence of significant hypoxemia, of FiO2 more than 50%, and OI more than 25, pulmonary hypertension due to failure of postnatal transition. Or positive response to nitric oxide. You started nitric oxide, infant was very responsive to, there is indication that nitric oxide is working well. Contraindication, that's more important to consider. You should not use nitric oxide if there's suspicion of total annulus pulmonary virus return. Or if there's congenital heart disease and you need the pulmonary vascular resistance to stay high to move the blood from the right side to the left side. For example, when you have hypoplastic left heart syndrome, you should not use even higher oxygen than needed. And then with left ventricular dysfunction, one of the phenotypes described, if there's LV dysfunction, it is contraindicated to use nitric oxide. Pulmonary venous hypertension. Sometimes echocardiography is very limited to diagnose pulmonary venous hypertension, and we need to do cardiac cath for that. So when you consider cardiovascular support, it is not empiric anyway. It is not the concept of using dopamine, dobutamine for everyone. It is based on the underlying pathophysiology. So vasopressor, when you have pulmonary hypertension or systemic hypotension, we prefer to use norepinephrine or vasopressin because both of them might improve the pulmonary blood flow. When you have pulmonary congestion or high pulmonary circulation, dopamine and epinephrine, both of them, they are known to increase the pulmonary vascular resistance. That's why when you have PPHN, it is preferred to use norepinephrine or vasopressin, not dopamine or epinephrine. But the opposite, when you have pulmonary congestion, you can use either one of them. When you have ventricular dysfunction, it is either dobutamine or merinone, as you know. And if there is hypovolemic shock or impaired filling of the heart, you need to use fluids, and steroids should be considered in refractory cases. Now, if you'd like to read more, you can refer to the Canadian Pediatric Society position statement on pulmonary hypertension, which was published in this article in a Journal of Perinatology. So 12 neonatologists trained in echocardiography from Canada shared in writing this statement, none of them from pediatric cardiology. Again, it is a typically neonatal condition. So this statement is very clear about the indications of nitric oxide and when to use and when it is contraindicated to be used. If you would like to read more and more about hypoxemic respiratory failure, refer to our book on hypoxemic respiratory failure in neonates. It's a very detailed book. Also, it is available online as ebook. And finally, that's the last slide about the algorithm. So just to summarize everything. If you have infant who's clinically suspected pulmonary hypertension, even if you don't have the echocardiography ready, you may consider a trial of nitric oxide to start with. And if the infant is responsive, very good. So it is pulmonary vascular resistance responsive to nitric oxide. But if the infant is unresponsive, you need to assess by our program, integrated hemodynamics program, which includes echocardiography, sometimes with near-field spectroscopy. And then you have two options. Either the issue is related to underfilling of the heart, you need to give more fluids, or it is RV dysfunction. So I think now you understand why I did not mention LV dysfunction. Because to begin with, if you are suspecting LV dysfunction, you should not use nitric oxide to begin with. So that's why I mentioned in this slide only RV dysfunction. And you have RV dysfunction, you have one of two options. RV dysfunction with systemic hypotension. In this situation, you need to use vasopressin. RV dysfunction with normal blood pressure or normal systemic blood pressure, then you can use merinone. Don't use merinone on top of hypotension, otherwise merinone might worsen the systemic blood flow more because of it is vasodilator drug. And then reassess again. If there is no improvement and the condition is still very critical, you can open the duct by prostaglandin. You can use prostaglandin in this situation, and then if there is no improvement at this situation, you have to consider ECMO and extracorporeal membrane oxygenation. Before you consider that, we should do CT angio. And CT angio for very important reason, because there is three common conditions that might be missed from echocardiography. One of them is pulmonary venous hypertension. The second type, when you have peripheral pulmonary hypoplasia, that might be missed from echocardiography and will be only diagnosed with CT angio or MRI with angio. And the third condition, when you have total anomalous infracardiac, that might be missed, and we have seen cases missed from echocardiography and diagnosed only with CT angio. That's why before considering ECMO, it's better to consider CT angio or MRI. And then ECMO might be the solution. Every year we see at least one or two cases might be escalated to the level of ECMO support, and they may stay on ECMO for a few days before reverse back to normal circulation and start to wean the cardiovascular medications. So I have three conclusions. So in pulmonary hypertension is a spectrum of multiple phenotypes. It's not just one disease. It's not equal to PPHN. Management is based on underlying pathophysiology. And then pulmonary hypertension is better to be managed by a neonatologist trained in echocardiography. It is typically a deep understanding of prenatal physiology and the fetal physiology as well, and like makes sense for the neonatologist to understand more about the spectrum related to perinatal related issues or perinatal failure of perinatal transitions in the previously mentioned situations. Thank you very much.
Thank you, Dr. Yasser, for the usual outstanding lectures. I will keep the question at the end.
Professor, can we, I have a suggestion for our colleague on the first line. It's very difficult for them to see the slide because it's high. So if they move to the upper part, it will be easier. And I tried down and up, it's better up a little bit.
So we apologize first for this not good resolution slides, but as Abdul Hakim suggests, comes in the middle to see more clearly. So now the time for the second lectures, I will leave it for my co-chairman, Dr. Abdurrahman Meheri. He's a consultant neonatologist, Force Hospital, Southern Region, Khamis Mushet. Dr. Abdurrahman, go ahead, introduce the second speaker.
Assalamu alaikum. Our next speaker is Dr. Ahmed Al-Zouani, who is a consultant neonatologist, Abha Maternity Hospital. He's going to talk about life-threatening condition that we are seeing frequently in neonatal units. So let's welcome Dr. Al-Zouani. He's going to talk about air leak syndrome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. First of all, thank you, Mr. Chairman, for your introduction. And I would like to thank the organizing committee for their invitations. Really, I'm very honored to present after leading speakers, Dr. Yasser. Thank you very much for your previous lectures. So I'm going to talk today about the air leak syndrome. Really, when I was asked by the committee to present about air leak, I remember one case when I was chaperone I came across. And really, I tried to concentrate myself and my slides about one item of the air leak syndrome, which is the pneumomediastinum. And these are my objectives. I will start by a case scenario, then we'll move to some anatomy and pathogenesis. Then we'll go through some cases has been reported in the literatures, and we'll have at the end, inshallah, some messages. So our patient, mom, she was 24 years old, G3 para 1 plus 1 abortion, and her antenatal blood were normal. Antenatal scan, she was seen at 21 plus 6 days and diagnosed to have left congenital diaphragmatic hernia. At 22 weeks plus 6 days, the LH ratio was 1.4 and the fetal echo was normal. At 30 weeks plus 65 days, the LH ratio was 1.6 and the ultrasound revealed the stomach and bowel herniated to the chest and heart pushed to the right side. At 34 weeks plus 6 days, the ratio was 1.8 and at near term, 36 plus 6 days, fetal echo was normal and structurally normal heart. So at birth in early afternoon, we have been called and the baby born blue with heart rate more than 100 beats per minute with some respiratory effort and weak cry. Intubated immediately because we have already the diagnosis, and Apgar score was 5, 7, and 7 at 1 and 5 and 10 minutes respectively. Cord blood gas was venous sample, pH 7.4, PCO2 31, and the base deficit was -2. Initially, baby need high pressure, almost to BIB reach 35 with beep 5 to have good chest expansion and good air entry bilaterally and mainly heard in the upper zone of the right side. Unfortunately, baby remained blue. SAT was 48% with a 5 to 1% oxygen. At 15 minutes of life, transfer to NICU, and the pre-transfer SAT was 45% with heart rate more than 100 beats per minute. On arrival, temperature was okay, 36.5, heart rate 190, blood pressure maintained. Saturation pre-ductal was 66%. So for that, switched to HFO and started on 9 now, and MAB reached 220. Frequency 10 hertz, amplitude 50, with the FI2 still 100%, and on 20 parts per million of INO. Echo revealed normal heart structures with BB chin and normal function. So this is the initial chest X-ray upon admission, and is matching actually the antenatal diagnosis with these left congenital diaphragmatic hernia on the left side. At 10 hours of life, baby remained desatting and saturations not improved on 100% of a 5 to 20 parts per million of INO. Vitally remains unstable. He was on morphine and some anitropes, dopamine and dobutamine. Mean blood pressure was 51, pre-ductal sat was 95, post-ductal sat was 69. Blood gas showing hypoxemia PaO2 was 27 and lactate was start to be higher. It's jumped to 4.4. And this is the follow-up chest X-ray at 10 hours of life. You can see here there's two pockets in the posterior pneumodistinum, and also there is air in the neck. So there is subcutaneous emphysema and with the posterior pneumodistinum. NGT was in place, USC was asserted, and also were okay. There was a crepitus, as we mentioned, as we observed in neck, and is explained by subcutaneous emphysema. Surgeon consulted, and the same diagnosis, left congenital thoracic hernia with posterior pneumodistinum, and intervention was not possible because of the clinical condition of the patients. Radiologist also seen the reviewed the X-ray with us, and his impression, the diaphragmatic hernia with query esophageal atresia. So because of this different, escaping of the air everywhere to the chest, so it's planned to win the map. Unfortunately, base start to desat more down to 70s, and with the persistent hypoxic respiratory failure, lactate jumped to 10.1. And you can see here now the air extended down to the abdomen. So there is a pneumodistinum, there is subcutaneous emphysema, and also there is pneumoperitoneum. At 19 hours of life, patient unfortunately arrested, CPR done, but died, and we sent him for autopsy. So the autopsy finding, the combined lung weight was 22 grams, and normal should be 40 to 50. Revealed left diaphragmatic hernia, all abdominal organ in the left chest except kidneys, and no perforation seen of the gut, trachea, or esophagus. No evidence of esophageal atresia or tracheoesophageal fistula. There was significant collection of air behind the heart, and is going with the posterior pneumodistinum. So we'll go to the some anatomy review and also pathogenesis. You know, the mediastinum lies between two pleural on the right and left side, and extended anteriorly from the sternum back to the vertebral column, and is divided to the superior mediastinum and the inferior mediastinum. The superior mediastinum usually started from the thoracic inlet to the T4, and the inferior mediastinum from T4 to the level of diaphragm or T12. The inferior mediastinum is subdivided to three parts, actually. It's anteriorly and middle mediastinum and posterior mediastinum. Anterior mediastinum from the sternum to the just above the pericardium. The middle mediastinum is just pericardium and heart content, and the posterior one is the just behind the pericardium to the vertebral column. In this view, just transverse section of the thorax showing the content of the middle and posterior mediastinum. And in this view also the dorsal view of the heart and lungs. And main things for this view is just to show you the hilum and where is it. Because the hilum is very important to its part when the air escaping from the lungs to the lung tissue to the different part of the thorax. So the hilum actually is the area or the part of the lungs when the bronchiole and meet the pulmonary vessels. And usually it's the lower resistant of the lung part. This is a pulmonary ligament in the right and left, and usually it's double pleural sheath arising from the mediastinal pleurum. I will concentrate a bit on the posterior mediastinum regarding the shape and the boundaries. As you can see in the cartoon on the right side, this is a regular triangular space. I draw this one just to make it very clear. And it's parallel between the 4th and 12th vertebrae, and boundary, as we mentioned, in the pericardium anteriorly and vertebral column posteriorly. The lower is bounded by the diaphragm, and superiorly by transverse thoracic line, laterally by the mediastinal pleura. The content usually for the posterior mediastinum is descending aorta, azygos and hemiazygos veins, vagus and splanchnic nerve, esophagus and thoracic duct, and some lymph nodes. So regarding the pneumodistinum, which is the main part for me today, this morning, which is actually has been reported in 1800, and is not very uncommon, but common cause in the neonate mainly could be spontaneous or assisted ventilations also can be iatrogenic cause, like rupture of the trachea or bronchus and rupture of esophagus, as we will see in coming slides, or trauma to the neck. Usually is benign, but rarely lead to the clinical significant and complications. So regarding pathogenesis, just we draw these lines and to make things very clear. Simply, just we have rupture alveoli, then the air will move from pre-bronchial to vascular sheath, and will move to the lower resistant part, which is the hilum, as we mentioned earlier. So usually the hilum is here, then will spread it anteriorly or posteriorly or around the heart and can cause the pneumomediastinum everywhere in the content. So in summary, this air can be extended up and can cause subcutaneous emphysema, can extend it down and can cause pneumoperitoneum, and also can cause pneumomediastinum, and in some severe form can cause pneumothorax. So we'll go to literature review and we pick some cases. Actually, there is not a lot of data or case reported in this part, but I try my best to get some reported cases. This paper has been published in 1979, and they tried to collect babies who had this finding, retrocardial air collections, and they collect 14 infants who showed the radiographically visible inferior pulmonary ligament air collection, which is the posterior pneumomediastinum, and while receiving assisted ventilations. So 12 of them, they were preterm and 2 terms. 10 of them were diagnosed basically on hilum membrane disease, and 1 neonatal pneumonia, 1 case of meconium aspiration, and the differential diagnosis beside our initial diagnosis of the posterior pneumomediastinum, it was iatrogenic esophageal rupture or hernia. Another paper, they collect 6 neonates, were on ventilators, and all of them, they were diagnosed as RDS, and 2 of them, they develop anterior pneumomediastinum, and 4 of them, they have posterior pneumomediastinum. All of them, they were diagnosed as the pulmonary interstitial emphysema. Unfortunately, 2 of them were died because of their disease, which is the bite changes, and also all of them developed pneumothorax. Survived 3 of them. They graduated from NICUs with the BBD and 1 sign of brain damage. So this some of their X-rays. As you can see, there is a persistent retrocardial hypolucency or air collections, and also some of them there is even air in the neck as extension from this pneumothorax. So the description, unlikely anterior mediastinum air, usually remains loculated, which is the anterior one, while the posterior one tend to be decompressed by cephal dissection into the neck or caudal extension leading to the pneumoperitoneum. The treatment usually responds very well to the initial disease, like bite changes or removal or drain the air and pneumothorax, but sometimes will take a time to be resolved completely. So we have 1 case here, was 28 weekers with RDS, as we are seeing in our practice. Surfactant given once, the patient became hypoxic and hypotensive after surfactant. So we did the X-ray, or they did the X-ray in these papers, and they found there is hypolucency area or retrocardial collection of the air, and they moved even for CT because this patient really was not improved with the conservative management. So they called the radiologist, and they insert 21 gauge needle under fluoroscopy guidance along with right paraspinal muscles into the mediastinal air, and they evacuate 20 mL of air, then the patient stabilized. So the message here, sometimes we need really more intervention for the pneumomediastinum to be drained out. In this papers have been published 2 babies. One of them was 26 weekers, intubated at birth for RDS, and chest X-ray ETT was so deep and refilled pneumomediastinum and pneumothorax. They insert chest tube, but patient not improved. Unfortunately, this baby at age of 6 hours, he passed away. So they did the bronchogram and showed there is tracheal injury or tracheal perforation. In same unit, they published 1 paper, 1 baby with who was 27 weekers, ventilated for RDS, developed bilateral pneumothorax, chest tube blazed with relief of the air. And the striking thing, during the insertion of the NGT, they have difficulty to insert it, and it was inserted under tension. And X-ray showed also retrocardiac air collection. So they diagnosed this patient with the contrast study as esophageal perforation, was managed conservatively by removing NGT tube for 2 weeks. Then baby, he did well. In this study, it was really a large series of retrocardiac pneumomediastinum. They collected 14 units with the posterior pneumomediastinum, and one of them was diagnosed with meconium aspiration syndrome with BPH, 12 with high membrane disease, 1 pulmonary hypoplasia with BPH. All of them, they were diagnosed to have bite changes, 13 out of the 14, pneumothorax in 10 patients, and pneumoperitoneum in 5 cases. And you can see here in the previous slides, even the air extended to the scrotum. So it was really a lot of air there in the mediastinum for these babies. So there was a strong association of retrocardiac pneumomediastinum with other manifestation of extra-alveolar air includes bite changes and also pneumothorax. Isolated anterior mediastinum is only occasionally associated with the dissection of air into the soft tissue. In this study, it was case report, 38 weekers who was born by the elective cesarean section at 23 hours of life. They developed respiratory distress and oxygen requirement. No cardiovascular compromise, and chest X-ray revealed anterior pneumomediastinum or Spinnaker Seil stain. We can see it. Really, we have seen it in our NICUs maybe last year 2 times. 48 hours, he developed respiratory distress resolved, and chest X-ray was revealed complete resolution at 60 hours of life. So mainly, we can say the anterior pneumomediastinum can be managed conservatively very well. Another case, 35 weekers, was born NFD, intubated and ventilated in the delivery room. Chest X-ray revealed anterior pneumomediastinum, and within 2 hours, he became hypotensive, tachycardic, and desatting. You can see there is no difference between the previous patient and this patient. There is anterior pneumomediastinum, but this one really is like tension anterior pneumomediastinum. So the team, they tried needle aspiration, but unfortunately they didn't succeed. So they called the radiologist, and he put a chest tube through the subxiphoid incision into the anterior mediastinum under the ultrasound guidance, and the patient improved. So sometimes really we need a lot of intervention for the simple pneumomediastinum. In this case, baby was preterm, 28 weekers, RDS, BDA, at day of 10, volume guarantee, he was in volume guarantee 6 ml per kg, sudden deteriorations and hypotension with desaturation. Chest X-ray showed pneumomediastinum, and the team actually, they thought about pneumothorax. They put chest tube, but it was not drained off. So they called the radiologist again, and they drain it. They put the chest tube in the second intercostal space and tried to hit this pocket. After that, the baby improved, and he did very well. We had a question before regarding the relation or association between the pneumomediastinum and pneumoperitoneum. So, and this study, they collect a good number of cases, and they try to differentiate which one is first, is the pneumomediastinum or pneumoperitoneum, or such as a sequel for the pneumoperitoneum. So they review like for 12 babies. 6 of them they were having intestinal perforation very clearly, and 6 infants they have pneumoperitoneum, but they have extra-alveolar airs like pneumomediastinum and also pneumothorax. And those 6 babies, none caused by gastric perforation, none had pneumatosis. None was clinically suspected to have neck. Abdominal radiography were available for umbilical artery review, catheter localization, it was good. And some of them, they went even for the OR, and no evidence of neck for them. So just a summary for those 12 babies. So you can see here for gestational origin, the presence of extra-alveolar air, nobody, no one of the 6 babies, they have any respiratory problems, and they don't have any pneumomediastinum. While the patient with respiratory origin and they develop pneumoperitoneum, all of them, we can say they have pneumomediastinum or bite changes. We have another case here has been published, and they mentioned regarding the tension the pericardial accumulation of the gas. This patient was 32 plus 2 days, emergency cesarean section because of antepartum hemorrhage, RDS, CPAP, at 14 hours, developed bilateral tension pneumothorax. At 14 hours of life, he got pericardial gas accumulation echo, revealed tension pneumopericardium, and pericardial synthesis done by cardiologist. and they get 60 mLs of air. But after that, at 50 hours of life, worsening respiratory acidosis and hypotension, and the X-rays revealed retrocardiac air. Echo confirmed the diagnosis. So they tried to evacuate this air by putting subxiphoid pericardiocentesis. Unfortunately, they didn't succeed. But even they called a radiologist, and he tried to put posterior needle puncture into the pleural space, not succeed. So they went for emergency left posterior lateral thoracotomy, and patient improved by the cardiothoracic surgeon. Lastly, this paper, or this case has been published this year, and it was 4 weeks old. This baby came to the ER with difficulty of breathing, and chest X-ray and CT scan even proved the diagnosis of anterior mediastinum with some air also in the neck, so going to subcutaneous emphysema. And he went for the rigid bronchoscopy, demonstrated isolated and vertical laceration in the posterior lanopharynx, hypopharynx. And there's a story behind it. The boyfriend of the mom, actually, he found this baby beside him, and he thought that he swallowed some foreign bodies. He put his finger and tried to get this foreign body, but he injured the hypopharynx to extent can cause this pneumomediastinum. So, in summary, spontaneous neonatal pneumomediastinum may be challenging diagnosis, and a false diagnosis of anterior pneumothorax could be wrongly lead to the inappropriate or potential harmful placement of the chest tube. When in doubt, just go forward for lateral decubitus and for ultrasound. And we have the expert by this time, Dr. Yasser, with us this morning for the chest ultrasound. And lastly, you can go forward even for CT chest. Most posterior pneumomediastinum resolves spontaneously with treatment of other complications like bite changes or pneumothorax, and consider surgical intervention for clinically affected and non-resolving posterior pneumomediastinum. Thank you very much.
Thanks, Dr. Ahmed. You save us good times. So we'll go back again to Dr. Yasser Sayed. And those who didn't hear him from the beginning, واحد من خريجي الأزهر من نور الأزهر الشريف في أرض الكرانة. He is now a consultant neonatologist at the Health Center of Science in Winnipeg, and he's also an associate professor at Manitoba University. Dr. Sayed will talk about another life-threatening condition, acute pulmonary hemorrhage. Dr. Yasser, the floor for you.
Yeah, thank you very much. Again for the kind of
Okay, less invasive surfactant. Lisa, you have 30 minutes, Dr. Yasser.
Okay,
Thank you.
I will do my best to finish in time. Okay, welcome back, everyone. So this presentation is a kind of hot topic, and use of surfactant currently considered as a priority to give it non-invasively in the era of non-invasive ventilation. To maintain non-invasive ventilation, you need to find a way to give surfactant without intubating the premature infants. So my topic, less invasive surfactant administration. I have nothing to disclose in this presentation. And just to show you our university, city of Winnipeg in Manitoba, that's a central province in Canada. It's a friendly city, although the weather is very cold. So I came yesterday from temperature around minus 15, and I came here, it was almost like even hot, more hot than the summer in Winnipeg. So I'm working at the Women's Hospital at HSC and St. Boniface. So Women's Hospital is a single room based in ICU. What does that mean? So the room that you can see in front of you is just for one single baby, for infant. And it is a baby and family-friendly unit. It means that we encourage parents to stay in the unit even for 24 hours. So at the back of the room, you can see two chairs. They can convert it to a couch, so the parent can stay overnight, can sleep in the room. And there is a TV in the room, there is a Wi-Fi, they can use internet, and they can use a washroom close by and stay in the lounge. With provided like 24 hours food and everything. So that's a kind of example for baby family friendly or integrated family care in ICU. So I have 3 main objectives to discuss over the next 30 minutes. At the end of this presentation, hopefully you will be able to demonstrate the evidence supporting use of LISA or less invasive surfactant administration, demonstrate the technique and visibility of different methods, demonstrate the clinical algorithm at the end. I have a clinical algorithm to help you to apply LISA easily at the bedside. And again, I have divided my presentation into 5 sections to discuss the previously mentioned objectives. First, I will discuss the physiology of lung protection in brief. Second section, different techniques of LISA. Then the evidence supports LISA. And then algorithm and recommendation. At the end, I have 2 recorded simulation videos just to show you how we use the most common 2 techniques in LISA, which is ENSURE method and LISA or MEST technique at the bedside, minimally invasive surfactant. So recorded simulation scenarios for you. And this presentation considered to be a short workshop at the same time. First, the physiology of lung protection. I just remind you, we have interventions known for bad outcomes, and we need to avoid as much as we can, including oxygen therapy, although the key of life, but it is bad for outcome, mechanical ventilation, I mean invasive ventilation, antibiotics, keeping the infant NPO or without feeding for no indication, or use of cardiovascular medications. We need to limit all of these interventions and to consider interventions good for outcomes. So as you see here, everything intervention from human potentially is bad, and everything from God is good. Breast milk, delayed cord clamping, skin to skin, CPAP, so let the infant breathe naturally as negative breathing technique, and just support non-invasively with CPAP and use of caffeine sometimes, and then surfactant. Typically non-invasive is better. So everything from a gift from God is good, and sometimes everything we do potentially harmful. So MAP, strategy for lung recruitment. Keep in mind that lung recruitment is a definition of recruiting the lung to FRC, functional residual capacity. So we need to get recovery to recruit the lung. So anything you do, you should aim by ventilation to recruit the lung to functional residual capacity. And then if you lose the functional residual capacity, it means that you have lung atelectasis and worsening of the clinical condition. You need to stabilize, you need to know how to recruit. And while recruiting, you need to monitor by oxygenation, ventilation, and hemodynamics. And while weaning, you need to maintain functional residual capacity. And if there is worsening, you need to reassess why the infant cannot maintain functional residual capacity. And the 2, by evidence, the 2 common, the most significant or 2 common things that can recruit the lung, help recruiting the lung, is non-invasive ventilation and surfactant. So we know from evidence now that less invasive ventilation equal to less lung injury, and a lot of articles, including meta-analysis that show that much less death and chronic lung disease when you use less invasive ventilation strategy. And the statement published by the American Academy of Pediatrics stated that CPAP started at or soon after birth with subsequent selective surfactant administration, just selective if needed, not as a routine. So there is no routine intubation for any gestational age or even 22, 23 weeks anymore recommended. There is no routine gives of surfactant unless it is indicated to avoid unnecessary intubation. So in neonatal practice after surfactant era, so surfactant indeed was a significant landmark discovery. After surfactant era, now we are focusing how to avoid intubation. So that's our current strategy, to encourage more CPAP, more non-invasive ventilation or non-invasive ventilation, even high frequency non-invasive or whatever mode non-invasive, and reduce intubation. And as you know, the impact of surfactant reduced mortality by 50%, especially for premature infants less than 28 weeks. Also decreases air leaks by 30 to 60%, decreases ventilator parameters, oxygen requirement, decreases IVH and NEC. But it did not change PBD, although the PBD increased in the era of surfactant simply because we have more survivals of premature babies less than 27 weeks. So more survivals, but they have more chronic lung disease. So we need to work on that. We need to limit the development of ongoing chronic lung disease by encourage more non-invasive techniques. So now I'm going to discuss different techniques of LISA. Historically, less invasive methods started by Ensure 1990. Typically intubate, administer surfactant, then extubate within 10 minutes. So extubate within 10 minutes. If you extend it, like if you keep intubated beyond that, it is not really Ensure. MIST, or minimally invasive surfactant, was described well by Hubert in 2012 in Australia, and he used a semi-rigid vascular tube to avoid using McGill forceps to introduce a feeding tube or suction tube. And then aerosol surfactant by nebulizer was described really early in 1997, but was not that successful at the beginning. But there is a recent trial showed it might be successful in mild to moderate RDS. Less invasive surfactant described well 2014 and became standard in Europe. And laryngeal mask airway recently also described. So in this slide or table, just to summarize the most common or most famous methods to be used in LISA or less invasive surfactant administration. And the methods highlighted in red color, you need to use either flexible catheter like feeding tube or semi-rigid tube like vascular tube. The methods in black color, there is no need for use of laryngoscope. There is no device that passes the vocal cords, typically like give surfactant to or nasopharynx, like the pharyngeal surfactant. So let the infant just inhale the surfactant through the normal breathing from the nasopharynx. Did not show like really effective, but is still under investigation. Or use of laryngeal mask, or use of aerosol nebulizer instead of giving the surfactant through the ET tube. So consideration for the best method. So how do we decide, how we select among these methods? So I just summarized in this slide how we can consider the best method based on the efficacy, the most effective method to treat the RDS, so means less ventilation and less need for second dose of surfactant, physiologic effect on infant, so like less need for oxygen, and more easier recruitment to functional residual capacity, pre-medication, less need for sedation, morphia, and so on. And patient population, is it better, which method is good for preterm, and which method might be good for late preterm or term infant? Effect on functional residual capacity, need for positive pressure ventilation, and potential adverse side effects, and then provider skills and familiarity with the device. Based on all of these factors, I have divided the consideration into 3 sections based on the category, method, issues, benefits, and evidence. So we have the less invasive in duration, so intubate just for short period of time, and typically we are talking about Ensure. And Ensure, you need to intubate, so intubation is needed. Analgesia with RSI, rapid sequence intubation, you need to give muscle relaxant, fentanyl, and BBV is needed during the procedure. So it's not really non-invasive techniques. There is some like aggressive or semi-aggressive procedure might be considered here, and there is delay in confirmation if the X-ray is needed. If you have a policy to confirm the AT tube by X-ray, like in our unit, you may need to wait longer time waiting for the X-ray confirmation, and we solved this problem. We are not relying on X-ray in our unit, we are relying on ultrasound. So high efficacy, so this is the benefit of using Ensure, because you are sure that almost 100% of the surfactant delivered to the lung, and there is no waste of surfactant in the upper airway or above the level of the airway. It is proven efficacy by literature. And then less invasive technique, you need to use soft nasogastric tube or semi-rigid catheter. And typically, the issues with this method, you have a device passes the vocal cords, so there is some aggressiveness in this situation because we have at least 1 or 2 cases reported in our unit for the last 10 years with the perforation of the airway because of the rigid catheter. Analgesia is needed, and positive pressure ventilation is not needed in this case. And then proven efficacy, it is proven efficacy. Least invasive technique, there is no laryngoscope needed, and there is no any device that can pass the vocal cords. So we're talking about laryngeal mask, pharyngeal tube, and aerosolized using nebulizer for surfactant. And unfortunately, we don't have a strong evidence to support that yet, although it is the least invasive technique. About the aerosolized surfactant, there is a recently published article in 22 units in US, and they found only helpful in mild cases of RDS to reduce need for intubation in about 26%, compared to 50% need for intubation for control group. For nebulized surfactant, keep in mind which nebulizer technique we are using. If you are using flow air for nebulizer, then the particles size will be even bigger than the terminal bronchioles. So terminal bronchioles in term infants 3 to 5 micron, and preterm infants 1 to 3 microns. If you are using nebulizer based on ultrasonic technique, then you are sure that you are getting the tiny small particles about 0.5 to 3 micron that might reach the terminal bronchioles. So that's very important consideration. When you have the machine, you have to be sure that the machine uses the ultrasound technique for nebulizer. So as you can see, you need the tiny particles to reach the terminal bronchioles. Using for laryngeal mask is another technique recently described. There is no reports that using a laryngeal mask might be associated with significant complications, so it is potentially safe. It is approved by NRP committee to be used for resuscitation. So it is a feasible technique, but we don't have strong evidence yet to support routine use of laryngeal mask to administer surfactant. So evidence to support less invasive or MIST, we are using both changeable as terminology MIST and LISA, but typically MIST was more described for use of rigid or semi-rigid tube that we are using in our unit, which is vascular access. LISA more for use of soft tube like feeding tubes for surfactant administration. Minimally invasive surfactant administration in this Cochrane study, which included 2,164 infants, showed that authors' conclusion administration of surfactant via thin catheter compared with administration via ET tube associated with a reduced risk of death or PPD, less intubation for the first 72 hours, and reduced incidence of major complications, which is really big achievement to improve outcomes in using this non-invasive technique. The most recent study, known as OPTIMIST study, unfortunately did not show the same results of the Cochrane review. So among preterm infants with respiratory distress syndrome supported with CPAP, minimally invasive surfactant compared to control group, treatment did not significantly reduce the incidence of composite outcome, death or chronic lung disease at 36 weeks post-menstrual age. So we consider the Cochrane review is stronger. There is actually published editorial of a concern related to methodology used in this study. Now we'll come to the algorithm and recommendations. So in Pediatric Canadian Society, there is a statement very clear about use of non-invasive techniques like CPAP with non-invasive surfactant as well. So in neonatal care settings where continuous positive airway pressure CPAP is routinely used to stabilize preterm infants, and when the rate of antenatal steroids, if you have in your unit the rate of antenatal steroids is more than 50%, then you need to consider prophylactic surfactant as no longer recommended as a routine. So there is no recommended prophylactic surfactant, no routine intubation for premature infants, even for very premature 22 to 23 weeks. We offer CPAP for them, and we just intubate after failure of non-invasive ventilation, and there is no routine surfactant anymore, assuming that the rate of antenatal steroids at least more than 50% in our unit is close to 90%. For spontaneously breathing infants on CPAP with RDS, non-invasive methods of surfactant administration such as LISA or MIST are preferred or preferable. Factors such as clinician experience, optimal dosage, volume, and types of surfactant available must be considered. And the grade of recommendation here is grade B, which is still high. I'll just explain in this slide our protocol, how we use the non-invasive surfactant in our unit. We integrate between MIST technique and Ensure technique. How? So if you have a newborn on CPAP of 7 after birth, right? And I'm talking mainly about preterm infants up to 34 weeks. So we are not using CPAP more than 7 before consulting surfactant. If the FiO2 more than 25%, and then you will be surprised, now we are not using X-ray anymore. We are using lung ultrasound. And lung ultrasound can give you a score instead of just looking at the X-ray and explain or describe X-ray as hazy. So that's not really very subjective way of assessment of RDS or differentiate RDS from TTN. So once we have like lung ultrasound score after birth for the first hour or two with the score more than 8, which is really supported by meta-analysis, and I will show you that later. A very strong evidence support use of lung ultrasound to diagnose RDS. And this ultrasound, who's doing ultrasound in our unit? The respiratory therapist. So we started with the physicians about to cover 24/7 for lung ultrasound service. We now were relying on RT. So the RT at the bedside with the ultrasound, just in 5 minutes, finish and report by himself without any supervision. Report and write all of the details on the system, and if the score more than 8, let us know, and then give surfactant. And the surfactant, if the infant's preterm less than 33 weeks, we use MIST technique. More than 33 weeks, we use Ensure. Why? Because in Ensure, we are using intubation, and more than 33 weeks, chronic lung disease is not really expected. So there is no problem to use Ensure to be sure that you are giving surfactant almost 100% of the volume given through the AT tube. So we're using Ensure for infants more than 33 weeks. For very premature infants, we prefer to use MIST to keep the infant stable on CPAP and give the surfactant non-invasively. And even the AT tube, the main issue now with the Ensure method, you need to wait for confirmation by X-ray. Even if you have an X-ray technician available just beside you, you may waste another 5 minutes extra waiting for the X-ray technique to be done. Again, we are not doing that anymore. In most of the cases, we assess the AT tube easily by ultrasound. So that can be done in just a couple of minutes and give the surfactant immediately instead of waiting. Even if you have the technique when the ultrasound or when the X-ray can be seen in the screen, so you don't have to wait for the X-ray to be processed through the system, it is still a waste of time. So we have this meta-analysis that showed that ultrasound scores very predictive even for chronic lung disease. So when we published, we actually conducted many studies in Canada and other studies in Europe, and we combined all of them in this meta-analysis, which showed that doing the lung ultrasound can predict chronic lung disease as early as the first and second week of life. So when you have a score more than 10, that's predictive that this infant most probably will develop chronic lung disease. And again, as I mentioned, using a score of 8, higher than 8, as a cut limit to give surfactant. So you don't have to wait more deterioration, require more oxygen, and maybe pneumothorax. So after introducing this technique, I can't remember when last case of pneumothorax happened in our unit, maybe last year or like a couple of years ago. Ultrasound is kind of dynamic technique. Instead of just X-rays, just one frame. Ultrasound, as you can see here, the infant is breathing, so you can see white out of the lung at the end of expiration, and there is some blackish color or A lines and end of inspiration. So the infant collapses and the end of expiration, and you can see that nicely on the ultrasound. You cannot detect that in X-ray because X-ray is one frame, and the one frame by chance can be in end expiratory or inspiratory. You cannot ask the infant to take a breath and hold the breath at the end of inspiration to take the X-ray as we do in adults. So simulation, I have 2 simulation videos. Each one of them is about 3-4 minutes, just to show you how we give the Ensure method in our unit, and another video about the MIST technique. So I hope the audio is working here, so I have the video. So there is no audio. I actually asked the technician about that. I tried to use the audio from the computer here. Sorry?
Just take the mic down.
Yeah. No, there is no still. Is there like a technician here available? So maybe I will describe the video myself. So you can see now the team. We have my colleague, Dr. Michael Narvi. He's our section head as well. And he's going to intubate, and you have the John Mineski, the respiratory therapist. This infant was given just 1 dose of fentanyl, and he's applying, as you can see, post-pressure ventilation for a few seconds. Yeah, ask it about the audio, and I'm not sure why it's not working.
They're improving now, so.
Sure. I'm using audio for the computer. Okay.
Okay, thank you. And then once we confirm the two positions, then we'll get back.
The room is very. It's okay. I'll just explain it by myself. Yeah.
You're up there. So you know
It's okay. No problem. Yeah, that's fine. Thank you very much. Thank you. Okay. So in just let me start again.
And I can see that it's ready. And we'd just like to get the saturations improving before we try to put the tube in. Okay, thanks John for doing that. Looks like the saturations are improving now, so why don't you let me have a look, and I'll put the tube into the Ensure. Do you have the endotracheal tube ready? Can I get it, please? Thank you. Okay, the tube's in. The baby's 2.5 kilos, so I'm putting the tube to about 8.5 centimeters. Okay. Uncheck the colorimetric detector. Can you have a listen? Thank you.
The color is turning yellow.
Perfect. Okay, so we're in.
And I hear equal air entry bilaterally.
Wonderful. And just to be err on the side of caution, I'd like to get the ultrasound in to check the tube position.
Okay.
Okay.
And I'll let you know. Let me just do a couple of breaths and I'll put a piece of tape.
Okay, thank you, John. And then once we confirm the tube position with the ultrasound, then we'll give surfactant afterwards, okay? Okay, thank you.
Hi everyone. So
I'm here to check the AT2 position, and we're just putting the probe over the suprasternal notch, and then I can see the AT2 position in the airway, and with a reasonable distance from the aortic arch. But to be sure about the depth of the AT2, I'm going to measure it. So now it is about 1.18 centimeter, which is reasonable distance between the AT2 tip position and the aortic arch, which is exactly above the level of the carina. So we are good. Thank you very much.
Thank you.
Okay, so we have the tube in a good position as we confirmed on ultrasound. So now it's time to give the surfactant. John, could you proceed?
So we've really changed our adapter. So we're going to be using this multi-axis catheter, and we're going to be giving the surfactant in two separate aliquots, and we'll be giving it as fast as the patient tolerates. So Michael, I'm going to just put this one here.
Okay.
Sorry.
And I'll just make sure this tube's in place.
And we've measured this one, so I'm going to go to 12.
Baby's vitals are stable.
Okay, and Mike, if you could hold off for 1 second, I'm just going to distract it. Okay, surfactant is in, we'll just give it a bit of a flush. And there's the first dose.
Thank you, John.
Thank you. Bang is stabilized, is everything good?
Yep.
Saturations are good.
Awesome, and here comes the second dose. And I'm going to just quickly put this down. And we can stop that thing for just 1 second. And move to the right spot. And here I go.
Patient's tolerating this very well.
Surfactant is done.
Wonderful. Okay. I'm noticing that this infant is still not breathing. Do you still have that Narcan handy that we had drawn up?
Yeah, I'll do that right now.
Thank you.
Okay, Narcan's in.
Okay, great. I'm starting to see some spontaneous movements here. Saturations are quite good. John, do you think this baby's breathing regularly enough for us to try next?
Yeah, it looks like the baby's breathing quite a bit.
Perfect.
Color's
Okay.
good.
Well, let's take the tapes off. And we have our CPAP ready in case the baby needs the support.
Yep.
Okay. Okay.
It's ready.
Okay, we're ready to hold the tube?
Oh, yep.
Okay, on the count of 3, I'm going to give a breath and then we'll pull. Okay, pull. Okay, and we have CPAP on. Okay, good job, everybody.
And how's he doing? Looking good?
Looks
Yep.
great.
I'll listen for air entry again. Sounds good.
Okay.
Okay, thank you very much. Now I think you realized that the time overall time was 5 minutes. So not even up to 10 minutes as described in the ENSURE method definition. And we saved most of the time that might be wasted in doing the X-ray by doing quick ultrasound. At the end, we have to be sure that the infant is breathing spontaneously. If it's still under the effect of fentanyl, is not breathing, we can give Narcan to reverse the effect of fentanyl. Now I'll show you in 2 minutes only the MIST
5
technique.
minutes left.
Sorry?
5 minutes.
Hi everyone.
Okay, we have
So I'm ready now to give the surfactant as minimally invasive surfactant administration by using angiocath. And I already prepared the angiocath, and I marked the marker at 8 centimeters from the tip, which is the same way of measuring the distance from the larynx to the lips in AT2. So we are going to give the surfactant to 2 kilograms baby. So we are using the marker at 8 centimeters.
Okay.
So 6 plus the body weight in kilograms. And at the same time, we'll keep the baby connected to CPAP. So we'll give the surfactant while the baby is getting the pressure by CPAP. And we are ready to intubate if we need to. So we have the setup ready.
We do, yes.
So we have the AT2 on
Yep.
side.
Yeah.
And we have the ambu bag.
Right.
Okay, and we have the surfactant rebuild. Thank you very much. So now I'm going to put the angiocath in using the Ranger scope.
Vital signs are stable.
Very good. So now I'm going to hold the angiocath with my finger against pellet.
And now I'm giving the surfactant. I'm going to be giving it much slower, just gently with the baby's respiratory rate, trying to let him breathe in the surfactant, probably about over 4-5 minutes.
Vital signs are stable.
And the first aliquot is in. And I'm seeing a little bit of surfactant come out, and I'm ready to give the second one.
Baby's tolerating well so far.
Very good.
And done. And I'm just gonna give a little bit of a flush with some air.
Baby tolerated well.
Very good. So now I can remove the angiocath out, and they're still breathing on CPAP.
Great.
And vital signs are maintained. Very good. Thank you very much.
Thank you.
Everyone.
Wonderful. So just in 2 minutes. So I have the final slide with the conclusion at the end. So both non-invasive ventilation and LISA are proven to decrease both long and short-term morbidities in premature infants. So we need to encourage more non-invasive techniques, either non-invasive ventilation, CPAP, or non-invasive ventilation by different techniques, like intermittent ventilation through the nose without need for intubation, or even high-frequency nasal ventilation. Afternoon today, we have a workshop, 3 hours workshop on non-invasive ventilation. So don't miss the chance to attend with us. And we have some case scenarios for discussion. So it is really a workshop on up-to-date knowledge related to non-invasive techniques. Ensure and MIST, as we described in this presentation, are the most effective methods so far to be used at the bedside. The other techniques like aerosolized surfactant and laryngeal mask used for surfactant are useful techniques. It seems that they are useful, mainly used in mild cases, but there is no good evidence to support routine use of both of them as of yet. And again, thank you very much.
Thank you, Dr. Yasser. Our next speaker is Dr. Khalid Al-Sidi. He's consultant, pediatric and neonatology from Medina Maternity and Children's Hospital, King Salman Medical City, Medina Munawwara. And he's the director of neonatal fellowship program. And he's going to speak about the pulmonary hemorrhage. So.
Assalamu alaikum wa rahmatullah. Thank you, Mr. Chairman and co-chairman, for introduction. I would like to thank the scientific committee and organizing committee for the invitation and giving me the opportunity to participate in this conference. And I hope all the best for our national team, inshallah, today. I will kick off my presentation with a case study. This is a 26-weeker gestation boy, day 2 of life. He was born spontaneous preterm delivery. Mom had annuated annual 1 week ago, and she had spontaneous preterm delivery. Quick delivery, had 1 dose of surfactant, of steroid, 1 hour prior to birth. Baby received some inhalation breath, and baby transferred on mobile and nasal CPAP to an ICU. Oxygen requirement increased, as well as the work of breathing at 6 hours of age. That's why he was given LISA, as we have just seen by Dr. Yasser. Increased work of breathing further at 12 hours of age, needed intubation and mechanical ventilation. Chest X-ray showed severe RDS. Baby became blood pressure unstable, and on the first day of life needed normal saline resuscitation, as well as commenced inotropic support. Second day of life, baby had deterioration and started having some blood from the endotracheal tube. So the case was neonatal pulmonary hemorrhage. The outline of my talk is to recognize early signs and symptoms of pulmonary hemorrhage, describe the pathogenesis and the risk factors of pulmonary hemorrhage in newborn, discuss the current option of therapy in the management of pulmonary hemorrhage, and finally, describe the outcome and prognosis. Pulmonary hemorrhage is a well-recognized condition in term and preterm newborn that was first described as early as 1855. It is typically an acute, catastrophic, often life-threatening conditions causing sudden deterioration in the infant's clinical conditions. The incidence of pulmonary hemorrhage varies between 1 to 12 per 1,000 live birth and can be as high as 50 per 1,000 live birth in a high-risk group. The mortality rate can be as high as 50% in a preterm infant. It is present in 7 to 10% of all newborn autopsies and up to 80% in VLBW, very low birth weight infant autopsies. Pulmonary hemorrhage occurs most commonly in the first days of life after birth, usually in the 2nd to the 4th day of life. It is defined pathologically by the presence of erythrocyte in the alveolar space, interstitium, or of the lung, or both of them. And clinical practice, the definition is a pulmonary hemorrhage defined as presence of hemorrhagic fluid in the upper respiratory tract or in the tracheal tube, accompanied by respiratory distress, which required escalation of respiratory support or intubation and mechanical ventilation. Massive pulmonary hemorrhage is a pulmonary hemorrhage that involves at least 2 lobes of the lung. The maternal risk factors for pulmonary hemorrhage are numerous, started with pregnancy-induced hypertension, toxemia, infection, bleeding disorders, medication, mother medication like vitamin K antagonist, anticonvulsant, lack of antenatal corticosteroid in a preterm labor, also a risk factor. The infant risk factor and the londonary risk started. The most common risk factor is prematurity, the most common risk factor, especially in LBW, extremely low birth weight infants, IGR, intrauterine growth restricted, respiratory problems, and sepsis, mechanical ventilation, PDA, coagulopathy, multiple birth, and hypothermia. Polycythemia, erythropoiesis fetalis, ECMO, urecycle defects, oxygen toxicity, and airway hemangiomas. So there is a lot of risk factor. Berger et al. Published in Journal of Perinatology in 2000, a case control study series, and he showed that antenatal corticosteroid has a protective effect regarding pulmonary hemorrhage. And Barbara Schmidt, in her TIP trial, published in New England Journal of Medicine in 2001, the TIP trial, which is the trial of indomethacin prophylaxis in preterm, pulmonary hemorrhage was among the short-term secondary outcomes studied. It showed no statistically significant difference was demonstrated between the indomethacin group and the control placebo group. Although, however, Dr. Khalid Al-Falih published in Pediatrics 2008 a post-hoc analysis demonstrated that during the first week of life, prophylactic indomethacin reduced the risk for serious pulmonary hemorrhage by 35%. Furthermore, he also mentioned in the report that the serious pulmonary hemorrhage doubled the risk of death or survival with neurosensory impairment. What is the size of the problem of pulmonary hemorrhage in newborn? This has been addressed in this study. It's a morbidity and mortality with early pulmonary hemorrhage in a preterm neonates, published in Archive Disease of Childhood, Fetal and Neonatal Edition, 2018, by Dr. Ahmed et al. And his group. And the study group, it was a recent group where the widespread use of antenatal corticosteroid and surfactant replacement therapy is the standard of care. And they were looking at association between early pulmonary hemorrhage and major morbidities and mortalities in large multi-center cohort in the United States of America. So the cohort included all inborn infants from 340 pediatric managed in ICUs within the state who were cared for from the day 0 or 1 of life through death or discharge from the unit between January 1st, 2005 at the end of December 2014, i.e. 10 years period. The total number is just shy of 600,000 infants cared for in these pediatric ICUs, of those babies, 2,000, almost 2,800 had pulmonary hemorrhage as a diagnosis. Out of them, for 1,476 infants less than 28 weeks had early pulmonary hemorrhage, and the definition of early, it happened less than 7 days of age. 1,363 constitutes 92% of the cohort were successfully matched with 2 control. And this table will show you the difference between this is the control and the pulmonary hemorrhage group. And looking at the patient characteristics, the only difference were the use of Bractin alpha surfactant given higher in the pulmonary hemorrhage group compared to the control. This is the only difference. The highest incidence of mortality, of pulmonary hemorrhage, was among the newborn born at the age of gestation age 24 to 23 weeks gestation, with pulmonary hemorrhage incidence ranging between 86 to 86.9 per 1,000 admission. And this was gradually declined at a higher gestation. It reached at a 32-week gestation around 1.9 per 1,000 admissions. Among infants less than 28 weeks gestations, at birth, pulmonary hemorrhage diagnosis was most common on the first day of life, constitute around 24%. In the second day, around 33%. Pulmonary hemorrhage occurred beyond the first week of life in 19% of cases. This is the table shows the patient outcomes in the match group. This is the pulmonary hemorrhage group, and this is the control group. If you look here, more RDS was diagnosed in the pulmonary hemorrhage group compared to the control, as well more Ehrlich syndrome in the pulmonary hemorrhage group. They had more grade 3 and 4 IVH compared to the control group, and they have also more periventricular shock and management for shock and PDA compared to the control group, as well as the mortality were more in the pulmonary hemorrhage group compared to the control group. This is Kaplan-Meier plot survival curve at the first 50 days of life in the matched sample. This is the group where they have no pulmonary hemorrhage, and this is the group where they have pulmonary hemorrhage. And it showed that patients with pulmonary hemorrhage at less than 28 gestation significantly excess mortality, which is most prominent in the first 10 days of life. And this is the survival, as we can see here, at all the level. In first week of life, the pulmonary hemorrhage group 40% compared to 19%. At 30 days of age, first 30 days, first 1 month of life, 54 compared to 28% in the control group, and overall mortality around 56% compared to 33%. Now, they look at now finally at the comparison between the survivor of pulmonary hemorrhage and the decedents, those who did not make it. And it showed that the survivor were having more antenatal corticosteroid exposure than the decedent one, and they were higher gestational age, 25 compared to 24 in the decedent one, and the heavier weight, almost 800 grams compared to 700 grams, and they have, of course, they needed less inotropic support compared to the decedent one, and they had less grade 4 IVH, but they have more incidence of PDA compared to the decedent one. What is the pathophysiology of pulmonary hemorrhage in newborn? Exact pathogenesis of pulmonary hemorrhage remains unknown. Most cases of pulmonary hemorrhage are secondary to hemorrhagic pulmonary edema rather than a true bleed. And the evidence for that, the hematocrit of the pulmonary hemorrhage fluid is 15 to 20% less than the hematocrit of the venous blood of the same baby. Several theories exist to explain the pulmonary hemorrhage in newborn. The first theory is by Cole et al. Published in Pediatrics 1973. He suggested that hypoxia leads to left ventricular myocardial failure. This will increase pulmonary venous pressure, and this will lead to pulmonary edema. Basically, what he's saying that hypoxia and acidosis lead to acute ventricular failure. This will lead to elevation of pulmonary capillary pressure, and this will lead to the sudden influx of hemorrhagic pulmonary edema fluid into the alveoli and cause pulmonary hemorrhage. The second theory is the stress failure of the pulmonary capillaries, leading to the breakage in the endothelial barriers, leading to the leakage of the hemorrhagic fluid into the alveoli. This is a theory published by Lancet in the Lancet 1992 by West et al. And the most popular theory is the PDA, which is currently the most acceptable theory as the cause of pulmonary hemorrhage in newborn. By decreasing pulmonary vascular resistance, increasing left to right shunting at ductal level, this will increase pulmonary blood flow, and this will lead to pulmonary hemorrhage. And other possible theories like surfactant dysfunction and intrauterine neutrophil activation in preterm RDS. Surfactant and pulmonary hemorrhage. What is the relation between surfactant and pulmonary hemorrhage? Surfactant improves lung compliance, as you know. This will decrease pulmonary vascular resistance, and this will lead to increased left to right shunting at ductal level, and this will lead to increased pulmonary blood flow and lead to increased risk of pulmonary hemorrhage. Roger Saul published in the Cochrane database of systematic review in 2010. He randomized control trial of 7 RCTs in a total of 1,583 premature infants. They concluded that prophylactic treatment with protein-free synthetic surfactant increased the risk of PDA by 1.11 odd ratio and relative risk ratio, and 95% confidence intervals ranging between 1 to 1.22. And pulmonary hemorrhage risk increased by 3.28, and with 95 confidence interval ranging between 1.5 to 7.16. Bandit et al. Published in Pediatrics 1995, a case control series in almost 787 VLBW neonate treated with surfactant, found that 94 babies, almost 12% of them, they had pulmonary hemorrhage. It was associated with increased risk of death. The odd ratio was 7.8, 95% confidence intervals ranging between 2.6 to 28, and short-term morbidity, odd ratio of 4.4, with 95% confidence interval ranging between 1.3 to 15.7 in a moderate to severe pulmonary hemorrhage. So what is the clinical feature of pulmonary hemorrhage? It's a fresh blood oozing from the nose and the mouth, or from the ETT or trachea, if the baby intubated, ventilated. Frothy pink tinged secretion are commonly followed by fresh bloody secretion. This is accompanied with worsening of respiratory distress and rapid clinical deterioration in the form of apnea, cyanosis, hypotension, and poor systemic perfusion, of course, with abnormal chest radiographic findings. Other clinical signs include hypovolemic shock, anemia, and bleeding from other side DIC. The axial X-ray can be as normal, quite as normal, and can be also a fluffy appearance in either side of the lung, or can be a ground glass appearance, localized or generalized, and finally can be severe, complete white out of the lung. Of course, as we have mentioned, echocardiography will show hemodynamic significant PDA. Differential diagnosis is direct trauma to the airway due to intubation or vigorous suctioning. It can cause pulmonary hemorrhage, or aspiration of the maternal blood. The investigation needed is complete CBC differential, coagulation profile, arterial blood gas, AB test if there is a suspicion of maternal blood suspected, and hematocrit of the aspirate. It might help differentiate between true bleed or hemorrhagic fluid, and ammonia level for urea cycle defect. The management of pulmonary hemorrhage, basically the goal of the management are mainly supportive. You try to control and stop the bleeding. Number 2, to improve oxygenation and ventilate and gas exchange. And finally, identify and treat the underlying condition. The immediate management is ABC. It should be centered around intensive care and centered around maintenance of the airway, breathing and circulation, including suctioning in the tracheal tube, maintain the patency of ventricular tube, mechanical ventilation, fluid therapy, resuscitation, nutrition support, analgesia, and sedation. Optimizing oxygenation as guided by pulse oximetry, and your positive pressure ventilation is to optimize increase the positive end expiratory pressure, and this has a thrombolytic effect. Hopefully this will minimize the bleeding, increase the mean airway pressure, so also give the same effect, and if it did not work, you might consider high frequency ventilation. Unfortunately, the level of evidence regarding the management of pulmonary hemorrhage in newborn are centered around the case control and cohort studies. Observation study only, and this is the only paper I found that have a systematic review impact on the management of pulmonary hemorrhage in newborn, published in September 2021. Actually, this paper was used the preferred revised reporting item of systematic review and meta-analysis guidelines from 1975 up to 2020, and they included out of after identification, verification, and excluding studies, 16 studies included, with total of 385 patients were included in this systematic review. The treatment for pulmonary hemorrhage were examined under the following outcomes. Number one, what is the impact of this management on the cessation of pulmonary hemorrhage? Number two, does it really improve the oxygenation and gas exchange? Does it really prevent recurrence of the pulmonary hemorrhage? And finally, what is the impact of the treatment on mortality and long-term disability? Most of the intervention can be as a primary intervention, and there is also adjunctive therapy can be given concurrently with prior to the medication, the intervention, or concurrent with it, or following the primary treatment. We'll start with the surfactant as a first therapy. Surfactant and pulmonary hemorrhage, this is in the Cochrane library. Dr. Abdelaziz, he tried in 2008 looking for any randomized and quasi-randomized control trial to do his Cochrane review, and he did not find any. In 2012, he repeated the same thing. He did not find any. And this is the last one he did in February 2020, and still there is no guidance for clinical practice based on the evidence from the randomized clinical trials can be provided at the present time. But paradoxically, there is some suggestion that surfactant may be used successfully to treat pulmonary hemorrhage, although a Cochrane review found no randomized or quasi-randomized trials that allow a firm conclusion to be reached. So we don't have anything from the randomized control trial. This is the table from the systematic review that I discussed. This is the 4 studies, and this is the 5th one. We grouped them together in one slide, and you can see here, it's a case report, one case here. This is also case report. Prospective RCTs, 42 patients. Retrospective case series, 27 patients. And this is the type of evidence that we have here. And this. So we have 5 studies in which surfactant was used as a primary treatment. They found it to be effective. So surfactant is effective in the treatment of pulmonary hemorrhage. It's effective in the sense that it can induce cessation of pulmonary hemorrhage and improve the oxygenation index measures. In the tracheal tube, adrenaline was also used as injective therapy with the surfactant, primary therapy. The type of surfactant did not have had any effect on the mortality rates or long-term disability. Recurrence of pulmonary hemorrhage did not occur in any of the 5 studies that used surfactant as the primary treatment method. Second, ventilation. These are the studies used ventilation, high frequency or conventional, and here we sum them up all. Number of patients here are better, 97, 18, 6, and 6. So what they conclude? High-frequency oscillatory ventilation and intermittent positive pressure ventilation were commonly used as a primary treatment method. Oxygenation indices showed rapid and significant improvement following 1 hour of high-frequency ventilation use and subsequent continued improvement in those infants who responded. It has been concluded that high-frequency was a safe and effective adjunctive therapy, rescue therapy treatment if the conventional ventilation failed. It has been noted that improvement in the venous blood gases and oxygenation indices following the infant receiving adjunctive therapy would increase positive end expiratory pressure. Hopefully this will have a tympanic effect and minimize the bleeding. Regarding ventilation, we'd like to also discuss our local experience here. Prof. Turki Al-Kharfi had published their experience from King Khalid University Hospital in ICUs and published in American Journal of Perinatology 2004 under the title of High-Frequency Ventilation in Management of Very Low Birth Weight Infants with Pulmonary Hemorrhage. The cohort was from the year January 1993 to December 1996, i.e. 4 years period. They had 248 VLBW infants during the study period. 27 babies, they had pulmonary hemorrhage. This is constituted around 11%. 23 of them were massive pulmonary hemorrhage with 9%, and among the severe pulmonary hemorrhage, there is 21 who had respiratory failure and 2 did not have respiratory failure. This table looks at the patient characteristics between the responders and non-responders to high frequency, and it was statistically insignificant, no difference between them. The responder here, 10 patients, and the non-responder were 7. And if you look at the AA ratio and the oxygenation index in the pre-intervention and post-intervention, I can tell significant improvement after 3 hours of post-intervention with high frequency. They used the infant star, which is the flow interrupters, and they give surfactant at that time to all the patients who went through high frequency. So they conclude that these results show that high frequency ventilation can facilitate adequate gas exchange in critically ill neonates with massive pulmonary hemorrhage and respiratory failure, and hence may improve their survival.
5 minutes, Dr. Khalid.
Epinephrine. This is a study discussed epinephrine as a primary treatment method. ATT epinephrine was the primary treatment method to utilize its effect of vasoconstriction and to increase the cardiac output for resuscitation and cessation of pulmonary hemorrhage. Pulmonary hemorrhage was stopped in most neonates following administration of 3 to 5 doses of 0.5 ml of ATT epinephrine, 1 in 10,000. This method was not only effective in treating pulmonary hemorrhage, but also minimizing the use of frequent suctioning of endotracheal tube. Coagulopathy was a commonly described in the conjunction with pulmonary hemorrhage. Vitamin K and as a vasopressor, and vasopressor were all have been used as treatment. Blood product, use of transfusion of blood, FFB, platelet, and backed RBCs was a common practice. Active recombinant factor 7 worked as in the extrinsic pathway and bind to the extrinsic tissue factor which ultimately will seal the site of the vascular injury and minimize the bleed. It is effective and enhanced effectiveness with the platelet co-administered, and has been used to cessation of pulmonary hemorrhage and return of normal hemostasis, which achieved. The use of active recombinant factor 7 is a dose-dependent fashion. Thus, it is formation of a fibrin clot. It causes cerebral venous thrombosis in adults, but never been reported in newborn yet. This is the last one, which is the use of hemocoagulase. Hemocoagulase is a newer treatment option. It is derived from the Brazilian snake venom, and it is a thromboplastin-like effect that also activates through the extrinsic pathway, tissue factor, and it has that convert the prothrombin to thrombin and fibrinogen to fibrin. The dose is 0.5 Ku through ATT every 4 to 6 hours until hemorrhage is stopped. And the effect of the coagulation, this is the study administered ATT hemocoagulase 28 preterm neonate with pulmonary hemorrhage. It reduced the length of pulmonary hemorrhage, the duration of mechanical ventilation, and also there is reduction in the mortality compared to the control group. The long-term neurodevelopmental outcome, most of the study did not discuss this further. So it showed that in this retrospective case control study, there were more predisposed to periventricular leukopenia compared to the control group, and they found non-significant lower among the infant with survived pulmonary hemorrhage. This table summarized the systematic review table. The keynotes of the systematic review that to date there is no systematic review exists to outline the best management of neonatal pulmonary hemorrhage in newborn. This study to discover that while multiple treatments are used, a multi-system approach is crucial, involving ventilation, persistent monitoring, appropriate use interventions such as surfactant therapy, high-frequency oscillatory ventilation, and increased mean airway pressure are needed. Further randomized control trial will be essential to further deduce the most effective management for neonatal pulmonary hemorrhage. The take-home messages: pulmonary hemorrhage is a life-threatening catastrophic event which is associated with a high mortality rate in neonates. A multi-system approach is crucial, involving adequate ventilation, persistent monitoring, and the use of appropriate intervention. Surfactant therapy, high-frequency respiratory ventilation, and increasing the mean airway pressure were found to be the most successful evidence-based treatment methods. Surfactant therapy was the most cited approach, although the timing of the administration and number of doses required to achieve optimal outcome is debatable. Evidence support that surfactant use as treatment for pulmonary hemorrhage is associated with the reduced mortality, pulmonary hemorrhage cessation, and improvement in oxygenation index, regardless of the type of natural surfactant administered. High frequency also shown efficacy and improving oxygenation indices. Understanding the etiology of pulmonary hemorrhage and optimal standardized management of coagulopathy and circulatory failure are vital to improve outcome by preventive and rescue measures. And thank you for listening.
Thanks, Dr. Khalid, for excellent review, saving our times. And now can I call my elite speakers, please, to the chair to start our question. We have maybe 15 minutes or 10 minutes for question. Everybody has a mic in front of him. Just raise your hand. I give you a permission. Press the key and start your question. Anybody wants to start? I will start myself. I will start myself as you are warming. Maybe we have one of our preterm here listening to the 3 lectures. And actually he opened his duct, he blew pulmonary hemorrhage, you give him a PEEP, he blew pneumothorax and air leak syndromes, you start to oxygenate him, you fail to oxygenate him, and then echo show BPHN. So how you manage this? The 3 presentation in one question. Preterm baby, open the duct, develop pulmonary hemorrhage, and develop the pneumopediastinum because of the PEEP, and now he ended up to have pulmonary hemorrhage. Go ahead. One by one.
Okay, you are right. This is what we are doing. As Dr. Yasser mentioned, whatever we are doing actually is not as superior as what have been. But going back to non-invasive, I think this is the solution. Non-invasive ventilation as well as non-invasive surfactant administration. Hopefully you don't need to go over the issues of, but regarding the surfactant, all the cases has been reported causing pulmonary hemorrhage. It was surfactant given a prophylaxis at that time. So I think recently now we are seeing less of pulmonary hemorrhage because surfactant now given on the need, not as we used to be surfactant given. This is my comment. Yes.
Yeah, thank you very much. Yeah, it was wonderful presentation. Yeah, thank you very much. It was a wonderful presentation on management of pulmonary hemorrhage.
So that wonderful question.
So the basics of premature management is ventilation. So priority to optimize, as probably you mentioned, and I mentioned, the functional residual capacity. And the priority for non-invasive as much as you can, and then you can escalate to invasive and intubation if needed. So lung recruitment, and we adopted a strategy to assess the functional residual capacity in what's called multimodal assessment or monitoring of lung functions by relying on ventilation loops and non-invasive assessment of ventilation perfusion mismatch. And I'm going to discuss all of these techniques in details in the afternoon during the workshop. So once we ensure that the lung recruited at the functional residual capacity regardless how much pressure needed. So we don't have the concept of PIPophobia. So in infant requiring higher pressure, we escalate the pressure either non-invasive or invasive until we reach the lung recruitment. Sometimes we use PEEP as high as 14 or 15, even non-invasive, excluding the postnatal transition, because during the postnatal transition, the incidence of pneumothorax is still high, or air leaks. We are talking about ongoing chronic lung disease, and the lung is probably more fibrotic, so the incidence of pneumothorax is much less. So lung recruitment to the functional residual capacity, so that's a priority. And then after that, if there is any, we need to assess the pulmonary circulation. If there is pulmonary congestion or pulmonary overcirculation because of the PDA probably, then we may consider to accept lower target saturation. That will increase the pulmonary vascular resistance, and then will limit the flooding of the lung with more blood. Sometimes it's difficult to treat the PDA immediately, and even if you give the medication, might work in 2-3 days and the infant's bleeding. So we may consider the non-pharmacological management techniques. One of them for sure to recruit the lung, give more pressure. And the second technique that we consider to accept lower target saturation. We accept 85 to 90. In our unit, typically in premature infants, 88 to 92. We are not considering 90 to 95 until the infant is beyond the ROP development stage, beyond 32 weeks. Before that, it is 88 to 92. And then just for short period of time, if there is significant flood of the lung, we consider 85 to 90, assuming that we assess the brain oxygenation at the same time. Because when you accept 85 to 90, the pulse oximetry is just measuring the standard deviation. So you may have 85 on the machine, but it is actually much less than that. It can be 81 or 82. So for safety, we consider another parameter to assess the oxygenation to be sure that the brain is getting enough oxygen, and we are using near-infrared spectroscopy. So NIRS in our unit is a routine for any critical infant during postnatal transition, or if the infant is requiring more oxygen or requiring more ventilation support. It's not routine for everyone, just routine for critical infants. So these are the new things that we consider. Using epinephrine is another technique, and we can be used as racemic epinephrine, nebulized epinephrine as well, or by endotracheal instillation. And we found that really effective in also acute hemorrhage. Treating the hematologically by transfusion, either fresh frozen or packed RBCs if needed or whatever, also can be considered as alternative. Last thing about, could be a really common practice, if you have infant with pulmonary hypertension, as a preterm infant and you have duct still open, it's really risky to give nitric oxide without monitoring. So if the PDA is right to left, in just 1 hour, it can shift to left to right with nitric oxide. So what we usually do in this situation, we may use nitric oxide, but we are not using the usual dose of 20 parts per million. We are using less 5 to 10. And then in 1 hour, repeat the echo again. Once we see bidirectional shunt or the PDA start to shift more left to right, then we'll wean the nitric oxide immediately, because that might end up by disaster, flooding the lung with more blood in no time. So you have, if you start nitric oxide in premature infants, very cautiously, or even any other pulmonary vasodilator like sildenafil, you have to be very cautious, monitoring the PDA continuously. Thank you very much. I hope
Thank you. Ahmed, what you will do with your beep and the pulmonary hemorrhage? The beep will stop pulmonary hemorrhage, but will cause more pneumomediastinum.
Back actually, regarding the ventilation strategies, I didn't know for as a sequel for the pulmonary hemorrhage to end by the pneumomediastinum. I don't think so. It's just to go back to the strategy of ventilation, especially lung recruitment and other stuff. That's it.
Faisal, تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you all the speakers for sharing the knowledge. I have a question for Dr. Yasser regarding the MIST and LISA. As you mentioned that for babies who are bigger, like 33 and above, we are using INSURE method. So do you think that it's worth trying, because we know that even as few as 3 to 4 artificial breaths can initiate the lung injury. So do you think that if merely the concern is to be sure that the tube is in, or we have a secure access to the trachea, so do you think that it's worth trying MIST via video laryngoscopy in these babies? This is the number one question. And the second thing is, if you could kindly...
So about considering INSURE method for older kids, typically I'm not sure about the statistics in Middle East or Saudi Arabia. Typically in North America, the rate of chronic lung disease is almost close to 0 for infants more than 33 weeks. So that's really unlikely if we get the tube in and like applying post-pressure ventilation for a few minutes, that might induce significant lung injury. Assuming that, which is very important, the technique, the team is really familiar with the technique, with the intubation from the first time. So you have expert person to intubate, and you have the assessment technique that can get the X-ray or ultrasound. If you have the person that can assess the AT2 position within the 10 minutes period. If you are exceeding the 10 minutes period and unable to do the INSURE method as described over a short period of time, or you don't have the team to intubate from the first time, then I agree with you. You can think about the alternative, which could be MIST. In MIST technique, we have seen that some babies might require second dose or so because there is lost surfactant while the baby is breathing. So that's a really issue about the MIST technique. In Europe, there is some center, they don't like, there is already a published article by Dr. Daniel Deluca in France. He is against using MIST even for premature babies because the same issue. Because we are not really sure about how much surfactant is getting into the lung. By Ensure, you are almost close to 100% sure they intubate the assess the 82 position and then give the surfactant adequately to the most of the under-ventilated areas in the lung by pushing the surfactant by positive pressure ventilation. So there is some controversy about the effectiveness of both techniques. That's why we said that's better to use Ensure for older kids when the chronic lung disease is unlikely.
Second question, Faisal.
Second question is about if you could kindly share your experience doing MIST in extreme preterm, like 25, 26 weeker. We do it, but we are a bit reluctant doing in very small babies like 26, 25 weekers.
Clear.
Yeah, like as per the lectures, not only my experience, any premature babies, even 22 weeks and above, there is no or minimal reported issues related to that, assuming that you have the team already trained and they know how to do the technique effectively and as per published recommendations. So in even the Cochrane review, there is just a few complications almost comparable to the conventional techniques of given surfactant. So there is no worldwide concern about using these techniques even for very small babies.
Jubara, then Imran, then Faleh. Fadl.
Thank you very much for excellent talk. My question for Dr. Yasser, two questions. The first one, again, LISA and MIST and the Ensure. We know when we started the LISA and MIST, like people, they have really longer time for administration of this surfactant, while in the Ensure, it's faster and we don't do the conformation of the endotracheal tube by X-ray. And even in the meta-analysis, I didn't think the size of the tube make a difference. ET tube is a bigger, but the technique is the same. You introduce it through the laryngoscope, the same technique, the same procedure, everything is the same. And if you take time, especially in a unit, they don't like wait for X-ray to see the tube. It's really shorter time to give the surfactant through the Ensure rather than through the MIST or LISA.
Your short comment?
Okay.
Just short comment, yes, Fadl.
Yeah, I think it's also depends on the familiarity of the group doing the technique. So in our unit in Winnipeg, before we introduced the MIST technique, we stayed almost 3 months. We did it as a quality project. So we had to be sure that more than 85% of the RTs, they are familiar with the technique. More than 85% of the nurses, they are familiar with the technique, and the physicians as well, and we started with the senior persons. So we ran it as 3 months cautiously, the most senior persons doing the technique and reported for any complications. The second and very important, the technique itself. If you are using the flexible or soft tube and with the McGill forceps, it's taking more time, and we haven't done that. And I think most of the issues might happen because of that. After we started the semi-rigid tube, either by angiocath, there is in the market now a very nice tube introduced with the stylet, built-in stylet. It is the same like ET tube with a stylet, and you can introduce it very easily, even with minimal experience or training, and get the surfactant administration done. The concept, again, about MIST in very premature babies, we avoid intubation or post-pressure ventilation, and it is in literature known that even 1 or 2 puffs by post-pressure ventilation, it causes lung damage.
Okay. دكتور عباس بدك تركيب معلش واحد عشان نكون تفضل عباس.
Thanks for the speakers.
Short question.
Yeah, the issue about pulmonary hemorrhage, it seems that we are dealing with different entities. I mean, like pulmonary hypertension, it's not one disease for treatment. So probably the treatment will depend on the cause. And then identifying the cause is the most important issue. The question here, in pulmonary hemorrhage of secondary to PDA, is there a way to predict those babies who might bleed suddenly and die suddenly with simple PDA?
Khalid?
As I mentioned in my talk, the most acceptable theory is the PDA related. But if it is mild PDA, I don't think it will cause the significant congested lung and cause the flooding of the lung with blood flow. And usually it happens in the first 2 to 4 days. This is the peak period of pulmonary hemorrhage, AL pulmonary hemorrhage. So you're talking about in the first 2 or 3 days of life. And duct expected to be open at this stage. And unless you have, you give in too much fluid, this maybe tip the balance and make it a larger PDA and make an imbalance and congested lung. Or it could have done a system like targeted echocardiography, and we heard you can follow your duct and see. But I agree with you, then treatment it goes to underlying cause. But if it is a PDA related, I think it's the issue here is to have to manage the PDA accordingly. Does it really hemodynamic significant or not?
Professor Faleh, short question.
I don't have a question, I have a comment.
تفضل.
It is for Dr. Yasser. It is quite obvious from your presentation and from the audience questions that LISA and MIST are very popular among neonatologists these days. Therefore, I would like to take the opposite direction with regard to LISA and MIST. We all know that PPD is a multifactorial process, and pathophysiology of PPD is a multifactorial, and honestly speaking, does not lie or depends on how you really actually give surfactant. We all know PPD in many cases start in the intrauterine life. Since the 1995 and beyond that, neonatologists and researchers in neonatal medicine have been trying to decrease the rate of PPD, and so far they failed. So far, if you look at all the large cohorts of randomized controlled trials and large cohorts over the last 10 years, we are fixed around a number of 30% PPD rate in the extreme low birth weight infants. No matter what we do, PPD still lies around the range of 27 to 30% of all the studies that are published for babies less than 1,000 grams. This even for CPAP, even for primary CPAP, without CPAP, your rates of PPD was 36, 37%. With CPAP as a primary mode of prevention, the rate of PPD went down to 30%. Now goes back to LISA because, as I said, it's quite popular. We like fancy things in neonatal medicine. However, when you look at your presentation, you only dedicated one slide of your presentation to the evidence, and most of your presentation was dedicated to present the technique itself. When you look at the Cochrane meta-analysis that you presented, it has 2,000 babies, and it has 16 studies. So by average calculation, the studies range between 90 to 100 babies in each study. When you look at the interventions inside the meta-analysis, it included all kinds of interventions. ENSURE, LISA, MIST against CPAP, MIST against ventilation and surfactant. So it was quite a heterogeneous group of studies and small studies looking at the prevention of bronchopulmonary dysplasia.
Yeah. Can you make it short, Prof?
Just my last point. When you look at the conclusion of that Cochrane review, the PPD rate was decreased by 40%. I cannot think of any intervention in neonatal medicine that decreased an important outcome by that range. I think we should think of the basics, go back to the evidence before jumping to introduction of new techniques in neonatal medicine. We need to make sure that they're safe, number one, and they're effective in reduction of bronchopulmonary dysplasia.
تفضل أخو خالد، تفضل ياسر. ياسر تفضل. Open your mic. Open the mic.
Thank you very much. It's a really wonderful comment. I agree with you. In Cochrane review, they included all of the non-invasive techniques, ensure whatever techniques. That's why the Canadian Pediatric Society, they comment that it is preferred, regardless what is the method. They did not comment, like they do not recommend any like specific method. And the other study, which is Optimist study, which was the largest study published so far in Australia, they did not report any kind of difference, which is against what is published in the Cochrane review. And it was the study was very specific about the technique, just one technique and all of the included units. Agree with you, chronic lung disease is still our big a challenge as a neonatologist. There is no any specific magic technique that can improve, but what we know from conclusion of all of the evidence that when you consider non-invasive techniques as much as you can and less interventions, less mechanical ventilation, because when you intubate, it means that you apply endotracheal ventilation even if it is for a short period of time, and that's known by physiology and by evidence. That's the worst thing that can damage the lung. So not everything from the evidence is clear and can be used as guidance. Like the evidence is full of garbage, sorry, and a lot of things that we have from the evidence might make our life miserable. So that's why when we integrate in our practice, we integrate physiology that makes sense, physiology with the evidence. How much on our practice, if you do round every day in the unit, in intensive care, high-level intensive care, how much of your decisions every day relying on evidence? I can challenge any one of you. You can tell me that 5 or 10% of your orders are written based on the true evidence, because we don't have really support for evidence for everything. That's why evidence we have to be very cautious. And because of the issues and the controversy related to evidence, I try more to rely on physiology. The physiology makes sense. And the physiology, it is based on very basic science-related research in animals or whatever. What we do today in antenatal steroids is based on animal studies, based on understanding from studies done on sheep, that we understand that antenatal steroids is the most effective technique to reduce the chronic lung disease and the associated morbidities related to prematurity. But thank you for your comment.
خالد وياسر اجتمعوا برا كده وتضاربوا على حدكم.
لا.
I have no evidence to extend my question. It's very valid point for Prof. Khalid. Very good comment to go back to physiology. You need to get a solution from this. And I thank the speakers a lot because we have no more times. You have 15 minutes of break. You are most welcome to invite to visit our exhibition, which is going to be the exit from here directly to the left side. From the entrance, it is going to be at the prayer area. We'll meet back again at 10:45. Thanks a lot for the speakers and the moderators. Shukran.